Hello again, everyone. Welcome to the Olympics of webinars in the dental field. So today we're very excited. We have all the way from northern Germany, Dr. Jochen Tunkel. Doctor, welcome. We're very happy to have you.
Thank you very much.
We're trying to get you all different corners and all different perspectives and diversity of different way of thinking. So we have one of the best clinicians in the world, in my opinion, and I'm a big fan of his work.
Thank
and
you.
and Dr. Tunkel, I'm going to read your bio very quick for people to know more about you, and then go from there. Dr. Tunkel have a German postgraduate degree in periodontology and another German postgraduate degree in oral surgery, Master of Oral Medicine Implantology. He's a specialist of the German Society of Periodontology. He is the founding of the online social media learning platform, Regenerative Bioversity. And he's an announcement as ITI speaker and as an ITI fellow. Admission at the European Centers for Dental Implantology. Visiting assistant professor, Department of Periodontology at the University Clinic of Münster, Germany. He's the chairman of the section of surgical periodontology of the German Society of Oral Surgery. Private referral practice for implantology, periodontology, and oral surgery in Bad Oeynhausen, Germany. I don't know if I pronounced it right, but
Quite good, quite good.
And he's a German postgraduate degree in oral surgery, Master of Oral Medicine and Implantology, 3 years postgraduate program in oral surgery at the Dental Clinic, Chairman Professor Dr. Curie, and the specialist of the German Society of Periodontology. And he's a postgraduate degree in periodontology, 3 years postgraduate program in periodontology at the Department of Periodontology, University Clinic, Münster, Germany, under the chairman of Professor Dr. Thomas Fleming. Wow.
That was a long way.
Very diverse, very valuable kind of education. Dr. Tunkel, welcome, and we're very happy to have you. And I know that you're very involved with the ITI as well, and doing your own webinars and educations as well. Today you're going to be talking mostly about regenerative bioversity. If you can tell us more about it.
Yes, we chose this platform, and it's an artificial word, as you already know, because I think that there is not just one way for rebuilding bony structures in implantology, but there are several ways. And I don't like it if it's too dogmatic. If someone says, I have the way and you have to use this way, and that's the only way that works, or the best way it works, I think you have to decide in every case, in every patient, again, what is the most feasible way with the least complication, with the less discomfort for the patient, and of course, with quite predictable outcomes. And I think there's several ways which I consider quite good and which I really like. And of course, there are several more ways that I don't do, and but that might be very good as well.
Well, personalizing it again, rather than generalizing it.
Yeah, right. But, that's the idea behind it. And of course, I learned in Professor Curie's clinic, and therefore I have learned a lot with the split bone technique. But I realized that there's sometimes it's very invasive if you do especially small things with autologous bone, and sometimes you don't even get enough autologous bone. And so my point always was to reduce the invasiveness and to get nevertheless good or even equal results to autologous bone. That's what regenerative bioversity is about. That's what I'm going to talk about today.
And the techniques in comparison to the materials and everything, you're going to be connecting this together as well, right?
Yes, I try to do as far as I can do in 1 hour, but that's something I'm trying to do.
Perfect. Doctor, you have your own private practice as well, I know, right?
Yeah, right.
With a very lucky patients, for sure.
Hopefully.
They are.
I don't know if they like me very much after I'm finished with them, but at least half a year after the procedure, they like me again.
I'm sure they do. It's normal that the patients hate us and then they forgive us afterwards. That's normal. That's dentistry.
Right.
So, Doctor, we're very excited and we're very interested to hear more about the lecture and go from there. If you would like to start, feel free.
Yes, I will do so. Thank you very much for the nice introduction.
Thank you.
So I think now I can change to my lecture. I have to start it. So hopefully everything works now. Otherwise, you have to give me a hint that it's not working. So I just already told you that what's the topic about it and what we are going to talk about, the variability of augmentation techniques. And I don't claim I have all the techniques in my lecture now, but at least I try to show you some of my techniques I use in my office. That's where we usually start. A patient with a severe periodontitis, and I like cases with severe periodontitis because I started my career as a periodontist, and we have usually a situation which is not that good after after losing the teeth. We have huge amounts of bone loss, and we have to get back again to restore the patients with implants. And it's not the point that we get implants of 12 to 14 millimeter lengths, as you can see here. We can discuss that very long if that's necessary to put such long implants. But for me, the most important thing is to restore the implants in the correct vertical and horizontal position. And therefore, we usually need, after losing teeth due to periodontitis, we usually need bone augmentation procedures. And if we do this in the right way, I think we can reach very predictable results, even in periodontitis patients. And of course, there are other things we have to take in mind, like supportive periodontal therapy. But of course, we have to rebuild the structures. And if you leave the structures like they are in the left pictures, you will probably have problems with pocketing again, just because there's a big difference of the attachment level of the neighboring tooth to the implant. And that's what I try to avoid by these procedures. So we have several things we can do, and several things that we might be able to use. We can use GBR procedure with resorbable membranes, with non-resorbable membranes like titanium membranes or EPTFE membranes. Of course, we can use, and we have to use, the sinus floor elevation. That's the procedure I left out completely today, because I think we are all accept that sinus floor elevation is a good and great procedure for bone augmentation, but there's not that much difference in the therapies there. And we have autologous bone blocks, and we have allogeneic bone blocks. That's kind of a new thing I do in my office. I do it since 3 years now, and I'm very, very happy about the results we reach with this. And I come back to these allogeneic bone plates later, of course. I start with one case, again, a periodontitis patient. The patient lost the front teeth, and we want to insert implants. And as you can see on the CBCT scan, we have some areas with a big horizontal bone loss and some where it's not that bad. If we go now to the clinical picture, that's something we very often see in the maxilla. The clinical picture looks fine, and we say, okay, we can start here, we put the implants, but later on we realize that the bony structures are not that good. So we have to be prepared for that. And I have to admit that I was skeptical about doing CBCT scans in implantology, or that we have to do it every time. And after some years having the CBCT scan, I really do it in every case, except there's at least very obvious that there's enough bone. And again, here I was lucky because I could insert the implants in the correct position. And later on, I did the procedure. Usually, most of the dentists doing implantology will do in their office too. I use the collagen membrane and DBBM, xenogenic particles for the GBR procedure, and I fixed the membrane. Something you will always see in my pictures here is that I like to fix the collagen membranes just with sutures. I seldomly use titanium pins for it. And after fixing and suturing, I wait 4 months with this procedure to go on with the second stage surgery. And the cases I show today, I always finish with the second stage surgery, because I usually do quite a bit of soft tissue procedures to regain keratinized or at least fixed mucosa, and of course to do something for the aesthetics later on. In this case, I used a connective tissue graft from the palate on the buccal side, and the graft you see between the implants is a free gingival graft, a thick free gingival graft, which I harvested from the tuber to put it between the implants to get some volume for the pontic area and to get at least some fixed keratinized tissue and some volume in the buccal area. That's in the upper picture, you see the patients after 5 months with the temporary restorations. All restorations you see are not mine because I really just do perio and oral surgery in my office. I don't do prosto, and so all prosto you see is done by my referring dentists, and I'm very happy to do nice work like they did here. And but what I saw here after 5 months is that the soft tissue is not, I didn't like it when I saw it the first time because I thought we didn't get enough keratinization in the bridge area, especially in the pontic area. But that was something that was really surprising to me after 2 years. That means 1.5 years after the first pictures, there was really a nice maturation of the tissues. And I think the final result is quite good for it. So if we have a procedure like GBR with a collagen membrane, it's working that fine, then we can say, okay, that's all we need. And patients will like it because I take everything from the box and I don't have to harvest any more material somewhere. But as you can see in this case, it's a very old case, one of the first cases I did. And there are several mistakes in the pictures, and a lot of you will see the mistakes and what I did wrong in this case, starting with the incisions, which I consider completely wrong in this case because I don't do any more relieving incisions in the frontal area. But I tried to augment this area just with collagen membrane and DBBM particles. And as you can see, the complete buccal wall is missing, the palatal wall is partially missing, and leading after 6 months to a really incomplete regeneration. And the question I always ask, and some of you, of course, will ask themselves, why I inserted the implant in this situation. I put in the perio probe on the right lower picture to show that the material in the area is not really hard tissue. Anyway, that's a mistake case where you can perfectly see that in huge augmentations, and huge doesn't mean that we need a lot of amounts of material, but it means in comparison to where we want to get, a lot of is missing of the area, and then we have not a situation using a resorbable membrane. So I like this procedure, GBR with resorbable membranes, and we do it quite often in our office, but we have to do it only in small augmentations. In bigger augmentations, it's not working very well. But if we like to stick to the GBR procedures, we can change to non-resorbable membranes. So let's have a look on another case. This is a case I did several years ago, and in the first you see that there might be a horizontal defect. The vertical is quite good. And after opening up, we see we have a quite sharp edge of the in the first quadrant. I did a small sinus floor elevation, and afterwards I did with a Gore-Tex membrane and titanium reinforced EPTFE membrane, I did the GBR procedure. And some may ask, do we really need the DBBM particles with the titanium reinforced membrane? And of course, we have several studies that we don't need it. I like to put it because it's if we have an early exposition, I think in my office, we have a bit better results if we have to remove the membrane quite early, that we have a more stable bony structure later on. We waited 6 months in this case. Now, if I do the procedure now, I only wait 4 months, but in this case, I waited 6 months, and this is really what we love to have after opening up with an EPTFE membrane. We really like these pictures, the bony structures, we have the blood supply of the bony structure, and this is really a very nice thing to insert, to put in the implants. Everyone will love this. And that's what we see when we see cases of GBR with EPTFE membranes, and that's why we always think this is a very nice method for doing bone augmentation procedures. Well, I let the implants heal another 4 months, and then opening up again, I told you that I always do some soft tissue management. And in this case, we did a apically reposition flap to gain more keratinized and fixed tissue around the implants. And there's the prostol situation 1.5 years after insertion of the implants. So we see we have a GBR procedure with resorbable membranes, which works very well and very nice in small defects. And we have as an alternative, we have the procedure with non-resorbable membranes, and we can do very, very big defects with this procedure. So I could finish my lecture here because that's all we need. But of course, all these methods have some problem too. And the biggest disadvantage of EPTFE membranes is the complication rates. And I show you one case where I got a complication. I inserted the implants here and worked with a different EPTFE membrane since the Gore-Tex was no longer available. And with this membrane, I had an early exposure. After about 2.5 weeks, we had a small dehiscence in the medial part of the flap. And what I learned during my perio times, I learned that if you have an exposition of an EPTFE membrane, it's always a complete failure. I can't state that, but it's very hard to keep the tissues clean, to keep the infection away from the augmented area. And that's why I try to keep the membrane 6 to 7 weeks after the procedure. And so I removed the membrane here after 7 weeks. And what we see is that we got a good bony structure in the beginning. And that's something where we can work with. We can proceed with our implantology. And at the end, the final result is not bad regarding that we have a complication. I hope I'm still online because I just checked once because we had some problems before. You can still hear me, I hope.
Yes,
yeah.
Yes.
Yeah. I have just to check because I was away twice in the beginning, so I just checked.
You're okay.
So let's have a look at the complications after especially vertical bone augmentation. And I like this study, which was done by Isabella Roqueta in 2008, because she integrated in the review not just prospective studies, but even retrospective studies. And as you can see, she compared 3 methods, which is GBR, distraction, osteogenesis, and only bone grafting with autologous bone blocks. And distraction osteogenesis had a very high complication rate. That's probably one of the reasons it is not that widespread procedure done by many dentists. I think only a very few dentists are really able to do this procedure quite well. And but what we can see is that GBR has a complication rate of up to 45%. And the interesting thing in that study was that there were 2 prospective studies in the GBR part, and they had complications of about more than 40%. And so the online bone graft is, considering complications, it is quite good, or let me say better than the GBR procedure. Nevertheless, last year, Istvan Urban published a new review regarding complications after vertical bone augmentations. And this was quite interesting because it was much different from the results of the Roqueta publication. Istvan Urban could show that GBR was the procedure with the least complications. And the interesting here in this study was that they separated the bone blocks groups into the shell technique and the complete bone blocks group. And the shell technique was the second was only 17% complication rate. To the shell technique, we provided one study. We had a lower complication rate, but the other study had a higher complication rate. But nevertheless, the GBR procedure was the best. I have to admit that. In my hands, I have more complications. I do it both ways. I had more complications with the GBR procedure, especially with the non-resorbable membranes. But of course, I have to admit that I learned the shell technique quite well during my oral surgery program because I did it with Professor Curie's clinic. Learns the GBR procedures from the beginning of his implantology work. And so we have to keep that in mind, that the procedure might not be that bad. Nevertheless, in my hands, I prefer the autologous bone blocks because I have less complications with it. So I do the bone blocks, the bone harvesting with the microsaw. As Professor Curie invented the microsaw, and as I learned in his clinic, I do the bone augmentation procedure, starting with the harvesting with the microsaw. Of course, you can use a piezo surgery device too. It's working quite well. It's just a little bit slower, but nevertheless, you can harvest big blocks with the piezo surgery too. And so we start with the bone harvesting. You use the microsaw to do the 2 horizontal incisions, a vertical incision, and later on the drill on the external oblique line. And what I don't do anymore is chin harvesting, because it takes much longer than the retromolar area, and we had more complications with chin harvesting, so I just do retromolar harvesting anymore. I want to show you one case where I did the Curie technique, and as you might see other cases, especially there's several cases published on Facebook at the moment. I do something different from most of these cases in vertical augmentation. I put my blocks on the buccal and on the oral side of the defect. I never put a vertical block on top. You don't have to, that's just the point, but you have the vertical block in the incision line, and that might lead to more dehiscences. If you do it like this, you really don't have problems, even if you don't use the tunnel technique, if you don't use semilunar techniques, you can just do a crestal incision and you don't have problems if you don't put the vertical block. So as you can see here, first I fix the buccal plate with 2 screws that are the outer screws, and with 2 more screws I fix the palatal plate. And the space that is provided by this procedure I fill with autologous bone chips. And that's really a very nice method. It's not too easy, you have to learn it, you have to take some time to learn it, but if you do this procedure, it's quite predictable. As you can see in this case, and the best thing about the shell technique is that we have very little resorption rates. I come back to the resorption rates later. As you can see here, watching the screws, it's almost no resorption here, and it's no problem to insert 2 implants, and afterwards another time of 4 months of healing for that. And as I told you, again, the Epically reposition flap for gaining keratinized and fixed mucosa. And this is the case 8 years after finishing the implantology. And we have a perfect bone stability around the implants. And we have to consider that the patient had a severe problem around the tooth before they got lost. So again, we have a very nice procedure working very good, even in big defects. Yeah? And so we have to ask, how can we compare these procedures? That's something we try to do always, especially using systematic reviews. We try to compare these procedures. And I took this graph to show that it's not that easy to compare the methods. This graph shows the amount of augmentation of the different procedures. And you can see perfectly that there's a big difference in the augmentation procedures, in the amount of augmentation. And of course, it's quite obvious. If we do a GBR study and we put in the implants and we do a small GBR just to gain up to 2 millimeters of bone, it's a big difference from a study where we do a shell technique to gain 6 millimeters vertical defects. And as you can see here, the destruction osteogenesis is usually used for very big defects. And but the shell technique, which I pointed the arrow on, is used or can be used for very big defects too. And that's a point we have to keep in mind if we consider complication rates, that the shell technique is usually used for greater defects. So if we really want to compare complications rates and other things, we have to do it in a split mouth study, or at least in a clinically controlled study. But we have to admit we don't have these studies. So that's something we have to keep in mind. In this systematic review, we had a higher complication rate, but we have a bigger amount of bone gain in the shell technique. So we have the perfect idea with the shell technique, and we could say that's enough, that's what we need. We have GBR procedures for the smaller ones, and we have the shell technique for the big defects. But of course, we have problems with the shell technique too. It's not that we have no complications or no problems with it. And I show you 3 long-term problems now, which I saw in my patients. Of course, you don't see them every time, but there are some patients where you see it. In the upper pictures, I had a patient, I did a vertical augmentation procedure, and you see the X-ray at the time of stage 2 surgery, and the patient was referred again after 2.5 years, about 2.5 years, and as you can see, we lost some of the vertical bone gain again. We have to ask, why did we lose the bone gain in this patient? Of course, there are several factors that might contribute to that, but we always have to ask, if we have an early vertical bone loss, what did we do wrong? Because in my opinion, bone loss in the first 5 years is usually due to failures of our procedures. And of course, we have to ask ourselves, what can we improve? The second line and the middle pictures show a case where I did a horizontal lateral augmentation. And after the lateral augmentation, I waited 4 months. And after these 4 months, you can see a severe resorption, which makes it very difficult to insert the implants. And I had to re-augment the area after inserting the implants. That's something we don't see that often in the shell technique, but from time to time we can see cases like this. So the question is, what do we do then? And the third case, again, is a lateral augmentation with a shell technique, and after waiting 4 months we could put the implants, no problem, you see the bone is fine. And about 3 years later, my dental hygienist enters my room and says, can you have a quick look at the patient? And I always know, as you all know, if a dental hygienist comes to your room and says, can you have a look? You always know there's a problem. Yeah? It's not just a routine control, because I would have been aware of the control before. And as I entered the room, I checked the patient and I took these pictures. You can see there's pus coming out from the pocket. And everyone will know what happens if I take a periodontal probe now, and it goes click, click, click. If I go on the buccal side down, the implants are no longer covered by the buccal bone. So what is the problem here, or what can we do to avoid these cases? First of all, we have to talk about bone resorption, because that's really one of the problems of autologous bone augmentations. And as I studied in university, I always was told that bone resorption of an autologous bone graft will be up to 30% of the augmented volume. And that's a bit too much. It's, in the studies, it's 21 to 25% bone resorption after full block lateral augmentation procedures. What we don't know is what happens after implantation, because these studies always look from augmentation to implantation and no longer. We have one study by Whitmark in 1997, which at least had a look from implantation to second stage surgery, and they did not found another 10%, which might the numbers indicate. They found another 35% bone resorption between these 2 time points. Of course, we have to keep in mind that in the Whitmark study, hip transplants were used, and in that times, usually the surgeon over-augmented the areas, because they thought we have to prevent augmentation by over-augmentation, which leads to quite the opposite effect, because if I go out of the bony area where we can augment, more resorption will occur, because I can't go out of the biologic area which we can augment. But nevertheless, we have to keep in mind that we have 21 to 25% resorption. And there were 2 groups which said, okay, we have resorption with autologous bone block, but we have very nice materials with the DBBM particles and the collagen membranes to prevent resorption, because the DBBM particles are usually not very well resorbed. And they said, okay, then let's combine these two materials. And that's something I really liked, is to find the advantages and the disadvantages of certain materials and try to make a combination to change these advantages and disadvantages and to have a better result then. And they had a perfect idea, and they had quite good results with it, because they could lower the resorption rate to 5.5% in the Cordaro study. This was a clinically controlled study. They had 21% resorption in the full block group without GBR, and to 7.2% in the von Arx and Buser study. And that's quite good, isn't it? But of course, like always, if you have one thing that gets better, another might get worse. And that was in these two studies, the dehiscence rate were with 3 of 11 cases and 4 of 42 cases quite high. And the even worse thing, in my opinion, was that the DBBM particles integrated quite well on the local bone. That's why I chose those two pictures, which are not mine, but out of the study. But it did not integrate at all on the bone, on the autologous bone graft. So there's something that's better and something that's getting worse. And so we have to ask, is this the perfect way now? And therefore, my friend Luca Di Stavla, with whom I worked at the Curie clinic my 3 years, had once the idea and said, so we can do this procedure in 2 steps. We can first augment the area with an autologous bone graft, and later on, we can, when we insert the implants, we have a second procedure, then we do the GBR procedure to prevent especially the bone from being resorbed later on. And as we know from the Curie, from the shell technique, that we have a lower resorption rate. So I show you a case of what we did then. We have here a patient with a horizontal defect in the 4th quadrant. And first of all, we harvested autologous bone from the retromolar area, and we did a lateral augmentation here. As I showed you before, we did the 2 lateral plates with 4 screws, and afterwards we filled all the gaps with autologous bone chips, which we gained from the bone harvesting, from the thinning of the blocks. We sutured the thing, and we wait 4 months again, and this is the result after 4 months. We have very, very nice, almost no resorption again, and we inserted the implants. And all of you will say, okay, that's perfect, that's all we need. We have a big buccal bone now. This is at least 1 to 2 millimeters we have of buccal bone. But nevertheless, we now did a GBR procedure. We did a collagen membrane, we did just 1 layer of DBBM particles. It's not that we want to over-augment the area much, but we wanted to have this relining area of DBBM particles in the surgical area. So what we found in this very small study, we did a very small study about this, that we only had a small resorption rate of the shell technique after 4 months of 5.2%, which is quite the same numbers as we had in the Cordaro study and the von Arx and Buser study. And we again found that once that the implants were inserted and we did the relining procedures, there was no further resorption of the autologous augmented area. And at least radiologically, there was a quite good osseointegration of the DBBM particles into the local bone. So in the short term, we had very, very nice results. And what we want to see in the long term is that this relining layer might protect the underlying autologous bone from secondary remodeling and losing the bone at all. I hope you can still hear me. Please give me a hint.